Hi, let's discuss this very high yield cardio question for USMLE step one. I'll start by sharing my screen. Right, so here we go. We have a 68-year-old man who presents to the emergency department with crushing substernal chest pain that began 3 hours ago. He's also diaphoretic and confused. His blood pressure is 75 by 45 millimeter of mercury. Heart rate is 118 per minute. Respiratory rate is 28 per minute. Oxygen saturation is 89% on room air. His extremities are cold and clammy. Jugular venous distension is seen. Bilateral crackles are heard at lung bases. The question asks us which of the following hemodynamic profiles is most consistent with this patient's condition. Firstly, we need to realize that this patient is going into shock, right? How do we know that? Number one, the patient's blood pressure is decreased. Number two, the oxygen saturation is decreased. Shock essentially is decreased perfusion to tissue for whatever reason. Here, because there is decreased here we can infer that the patient is going into shock because there's decreased oxygen saturation, which means the tissues are underperfused, and also because there's the BP is decreased, which is also highly suggestive of underperfusion. Right. So here we can also see that the question stem tells us that the patient presents with crushing substernal chest pain, which is very buzzy for acute myocardial infarction. The question stem also tells that there's jugular venous distension and bilateral crackles heard at lung bases. Both of these things essentially mean that the patient has heart failure because the heart is failing as a pump. It is not able to pump blood efficiently into systemic circulation, leading to decreased blood pressure, and all the blood is transmitted backward into the left atria and then into lung in the pulmonary vasculature and then into the central veins. So it is giving rise to this clinical presentation. I'll discuss this more elaborately in the next slide. But basically, what we can infer is that the patient has acute myocardial infarction complicated by cardiogenic shock. Right? Now, let's understand cardiogenic shock in detail first. This is an illustration which I got off the internet to explain the concept of cardiogenic shock. So what happens in cardiogenic shock is the etiology, the most common etiology is acute MI, right? It can also be due to arrhythmia or valvular dysfunctions. But the pathophysiology is that the heart fails as a pump, which leads to so if I had to show you in the diagram, the left ventricle usually pumps blood into the aorta, into the systemic circulation through the aorta. But when it fails as a pump, so in acute MI, the cardiac musculature is also underperfused like any other tissue in the body. So it leads to decreased contractility, which causes decrease in the ejection fraction and thus a decrease in stroke volume and the cardiac output. Thus, the cardiac output is decreased. Now, the blood, because the ejection fraction is decreased, what happens is the left ventricular end diastolic volume goes up, which means the left ventricle is partially filled. It remains partially filled, right? And then during the diastole, when the mitral valves open, this pressure is transmitted backwards into the left atrium. And pulmonary capillary wedge pressure is nothing but an indirect measure of the left atrial pressure, right? For all intents and purpose, that's what you need to know about the pulmonary capillary wedge pressure, that it is an indirect measure of the left atrial pressure. For the curious ones out there, it is called pulmonary capillary wedge pressure because how we measure it, we advance a Swan's-Ganz catheter into a small branch of the pulmonary artery, we advance it up till the capillaries, and then we inflate it with a balloon, wedging it there. And then when the pressure is measured beyond the catheter, Uh, it reflects the pressure transmitted from the left atria into the pulmonary capillaries through the pulmonary vein, right? So it is an indirect measure of the left atrial pressure. We can't measure the pressure of left atria directly, right? It would be very invasive. But for USMLE step one purposes, all you need to know is that it is an indirect measure of the left atrial pressure, which goes up in cardiogenic shock, right? Um, Then we have the CVP or RAP. CVP is central venous pressure, RAP is right atrial pressure, and both of them are essentially the same because CVP because the central veins drain into the right atrial pressure. So the pressure is essentially equal of right atrial pressure and the central veins. And this is increased because if the heart failure is extensive, we can intuitively think of it, right? So similar to how the pressure is transmitted backwards into the left atria, if the heart failure is extensive, the pressure can be transmitted further from the left atria into the pulmonary vasculature. So from left ventricle to left atria, from left atria to the pulmonary vasculature, and then from pulmonary vasculature into the right heart, and from there into the central venous system, right? So and when there is a pulmonary congestion because of backflow of blood here, that it leads to pulmonary edema, which leads to crackles. So when alveoli open up, uh, they crackle, they create this very buzzy crackling noise, which is suggestive of pulmonary edema. And because of pressure transmitted into the central venous system, it leads to jugular venous distension. The blood pressure is low, right? Blood pressure is the product of cardiac output and systemic vascular resistance. The cardiac output goes down, and thus the blood pressure also goes down. The systemic vascular resistance is increased. The reason being, when the cardiac output goes down, it is sensed by the arch of aorta, the baroreceptors in the arch of aorta and carotid sinus, right? And this baro and these baroreceptors stimulate. When these baroreceptors are stimulated, they lead to an increase in the sympathetic tone. And when sympathetic tone is increased, it leads to vasoconstriction to compensate for the decreased cardiac output, right? And now the more astute ones amongst you must be wondering, if SVR goes up and cardiac output goes down, shouldn't blood pressure remain same? Why does the blood pressure go down? And the reason for that is that by definition, shock means when blood pressure goes down. As I mentioned, it is a product of cardiac output and systemic vascular resistance. Uh, the body can only compensate for decreased cardiac output up to a point. When cardiac output is drastically decreased, the the body can no more compensate for it by increasing the systemic vascular resistance, and then the blood pressure goes down, and then the patient is said to have gone in shock. So now going back to our first slide, here we can see that. Now let's discuss, right? So the cardiac output should go down, so we can eliminate option A. The pulmonary capillary wedge pressure should go up. Thus, we can eliminate option B. The systemic vascular resistance should go up also. And that is why option C is the correct answer. Right. Uh, so we have gotten our correct answer. Now let's just quickly go through this last slide. This is a snapshot of a table from the first aid. Uh, Now discussing this table it is a tabular representation of all the hemodynamic parameters, all the changes taking place in the hemodynamic parameters in different type of shocks. Now, going through the whole table in detail is outside the purview of this video, but what I'll do is I'll quickly go through points which will help you differentiate cardiogenic shock from other type of shocks. Firstly, hypovolemic shock. right? Hypovolemic shock is due to decreased blood volume. And when blood volume decreases, the cardiac output goes down, but also the pulmonary capillary wedge pressure goes down because there is a decrease in the left ventricular and diastolic volume as well. So that's the differentiating factor. PCWP goes down in hypovolemic shock as opposed to going up in the cardiogenic shock. Obstructive shock. Now obstructive shock can be due to various etiologies. It can be due to cardiac tamponade, it can be due to pulmonary embolism, or also due to tension pneumothorax. And the hemodynamic parameters can mimic cardiogenic shock, right? So the only way to differentiate between cardiogenic shock and obstructive shock essentially is uh, looking at the clinical picture. For example, if a person had pulmonary embolism, he would have shortness of breath. If he has pneumothorax, there would be decrease in breath sounds, right? If there's cardiac tamponade, there would be muffled heart sounds. So that's so when so the clinical picture gets very important when we have to differentiate between obstructive shock and cardiogenic shock. And then we have distributive shock. It can be due to neurogenic injury or due to, I mean, it can be either neurogenic shock or septic shock. In both of these conditions, what happens is the essential circulating volume, the effective circulating volume uh, of blood decreases, right, leading to decrease in pulmonary capillary wedge pressure again, uh, because the left ventricular and diastolic volume goes down, so the pulmonary capillary wedge pressure also goes down, and that's how you differentiate uh, all the different kind of shocks from cardiogenic shock. And that's all you need to know for that's all you need to know about cardiogenic shock for the USMLE step 1. Thank you.